We are on air. Dear colleagues, dear viewers of our today's meeting, of our today's discussion, I would love to greet on the side of the Russian Society of Interventional Cardiologists, and we will talk today about the optimization of the results of PCIs. I would love to say that there is a good tradition to perform every year our meetings, and we do it together with Global Health Partnership. And our first meeting happened in 2019 in Moscow. It was a conference where we met face to face. Pandemic changed our work, and our society decided to continue our work online. Nevertheless, the level of discussion and the level of presentation would not change, would not suffer, and all the participants of our webinar will ask questions, and I think that we will have very interactive and interesting for everybody discussion. So why the topic is chosen? It is due to the life situation, because we all see that our everyday practices in our cath labs demonstrate the increase of patients with complicated lesions or with advanced age, 75 plus, with calcified arteries, with multiple lesions. And it means that we need to exchange our opinion how to treat these complicated lesions. And our today's webinar and discussion is dedicated to these issues. I want to present with great pleasure our participants. We have international discussion today, and today here with us we have presenters who we know really well. These are prominent international speakers. They are well known in international society. So you know that here is Alexander Abizide from Brazil, from São Paulo. They have summer now, and I envy them. In Moscow, it's winter and minus, while it's so warm here. Alexandra, good morning. I presume it's morning. Yes. I also greet Andres Ergelis from Latvia, Riga. We meet him very often. I see him only on the screen, but I'm very happy to see you one more time, though not in personal, but you look great. You look great. And we have also a friend from Serbia, Dejan Milasinovic. I'm glad to see you. And from Russian side, we have presenters. We have here Professor Shibushkin. Great to meet you. Mr. Alexei Sazykin from Central Clinical Hospital of Russian Academy of Science. And I will be also here with you. And I would love especially present Kate Oldroyd. He is from the Great Britain with us, and he will be our moderator. And I hope with his help, we will actively discuss all the important issues. As most of the audience is Russian speaking, but for Russian, we have CIS countries listening to us, the people where we have a Russian speaking audience. Nevertheless, we know we have English speaking audience. So you can listen to our discussion both in Russian and in English, as the simultaneous is there. I hope it's of nice quality, and you will get the full information and precise information on our discussion. That's all from my side. And I pass floor to Kate Oldroyd to moderate. Please, Kate, join, and you will be the moderator, and we will help you, and join during the discussion.
Thanks for that introduction. And yeah, we do have complete opposites here with Professor Abizaid in the warmth of Sao Paulo and the Russian audience in the middle of winter. I'm kind of in the middle here. I'm in Ireland at the moment, and the weather is quite spring-like. So we have 10 degrees centigrade. So I guess that's somewhere in the middle. So Professor Abizaid is going to kick off with a very important discussion on the consequences of bleeding. Of course, all patients having PCI are at some risk of bleeding because they're usually on dual antiplatelet therapy or sometimes triple therapy afterwards. But some patients have higher bleeding risks than others, and the consequences can be quite different in different patient groups. So thanks very much, Alex, for giving us this talk on the consequences of bleeding today.
My very pleasure, Keith. Good morning from Brazil, sunny Brazil, almost 30 degrees, and good afternoon to my friends from Russia. Again, a special thank you for the Russian Society for this wonderful initiative, and also to Biosensors to help to sponsor this event, which is one more edition of the Advanced Therapy Symposium. And a pleasure to be with you today and to be able to interact and learn from my friends from the other side of the world, how they treat complex intervention. But my mission in this next 15 minutes is to discuss with you something that we ignored for many years because we are so focused on treating the coronary obstructions that we kind of forget that there is a price to pay. When we have stable patients with complex lesions, that we have to be very aggressive with antiplatelet therapy and anticoagulants. So needless to say to this mature and experienced audience that we evolved in this past few decades. We started with heparin and aspirin, and now we move to much more aggressive drugs that can really inhibit ischemic events such as ticagrelor, prasugrel, and perhaps the combination of several antiplatelet therapies with anticoagulation. So being said that, I think that helps us to avoid thrombotic events, but the price we pay for bleeding is not trivial. So when we talk about ischemic complications, we think about MI, death, stent thrombosis, and urgent target vessel revascularization. But on the other side of the scale, we see that hemorrhage, transfusion, thrombocytopenia, those are complications that can lead to mortality that in the past we kind of ignored and didn't pay too much attention. So now the beauty and the sweet spot is to balance between ischemic complications and bleeding. So let me summarize some of the old data, which is now almost 20 years ago, with 24,000 patients from the GRACE registry, that this slide is extremely clear when it shows that independent of the presentation of a stable angina, non-ST elevation MI or ST elevation MI, there is a much higher mortality in patients who bled as opposed to the patients that did not bleed. So I think that that's something that we should think and remember when we treat these complex patients. So mortality is much, much higher in the patients that underwent PCI and had a major bleeding. So then subsequently, we learned the most important predictors of bleeding, which is advanced age, female gender, renal failure, previous history of bleeding, atrial fibrillation, because we generally give anticoagulation together with aspirin and clopidogrel and other drugs, and 2B3A antagonists. So those are the early predictors that we learn very soon. Then also Greg Stone published the results of REPLACE-2, And you see, when you see the independent predictors and the odds ratio of bleeding as compared to MI, so those face-to-face is again, bleeding complication versus ischemic complication. You see that bleeding kills much more than ischemic complications such as MI. So MI is 2.7 and major bleeding is 3.2. So we are talking about higher risk for mortality, bleeding versus myocardial infarction. So this is a good learning. And also when you compare here myocardial infarction with any bleeding, including transfusion, you see that this major bleeding that requires transfusion are much higher, 4 times higher than, for instance, MI, which is 2.5. So again, we are so focused and so paying attention to myocardial infarction that we kind of forget in-stent thrombosis, that we forget about the consequence of bleeding. And this is another important graphic that shows patients with no bleeding, and again, patients with bleeding in red, you see the mortality is almost 15% as compared to patients with no bleeding but had a myocardial infarction. So again, this is the worst, perhaps the combination of both is even worse, but that shows you the relevance of bleeding in terms of mortality, both early on in the first 30 days and at the end of 1 year. So I like the meta-analysis that put together more than 30,000 patients with several studies that now we realize that perhaps we should be less aggressive in terms of timing of prolonged depth. So most of these studies are comparing early depth versus prolonged depth. And you see here the acronym of these most popular studies here. And if you see, the only trial that showed reduction in MACE at the end of 1 year is when we adapt DS that they gave dual antiplatelet therapy for prolonged time, close to 2 years even. This is the only trial that showed reduction in MACE. However, most of the trials, most of them that had more prolonged depth, they showed significantly more bleeding. So the translation of this data is to say that if you give too much prolonged depth, you're going to cause more bleeding, and perhaps you're not going to benefit too much in terms of MACE, because this is the only trial that showed some reduction in MACE. So be aware that prolonged depth can cause more bleeding. And again, this is the odds ratio and attendance of longer depth will cause more problems than short depth. So this is something that we learned. And you see here that there is a 49% increase in non-cardiac mortality with prolonged depth, and 72% increase in bleeding when you do have prolonged depth. So again, more benefits towards short depth because you cause less bleeding, and again, you don't change too much the reduction in ischemic events. So I think that's a good teaching point for all of us. And here you see that in this big meta-analysis of, again, more than 32,000 patients, for one stent thrombosis that you save with dual antiplatelet therapy, you cause 2.1 more deaths and more bleedings. So I think that the balance here is, again, when you try to save ischemic events and be more aggressive, particularly with timing, with the prolonged depth, you're going to cause more bleeding, and you're not going to save too many patients in terms of stent thrombosis. So this is the slide that I put together more than 15 years ago at ACC, when I was invited to speak about novel drug-eluting stents. And during that time, I thought that, you should abandon the durable polymer platforms, move to bioresorbable polymeric platforms with metallic stents. And the ideal situation would be no polymer, and even more ideal is bioabsorbable scaffolds. You know the story about bioabsorbable scaffolds. I think that we still need to learn more. The first generation didn't work so well. But again, moving from a more durable platform, polymer, to non-polymeric, I think is probably the ideal situation. And I think this is one of the rationale for platforms such as BioFreedom that change the surface of the stent to absorb drug and deliver to the vessel wall with a no polymer, because it's one less inflammatory agent to the vessel wall. So I think that's the rationale. And again, we have to think about these patients that will undergo unplanned surgery, a recent stroke, anemia, need for anticoagulation because they received a metallic valve, cancer, not to mention advanced age. This is a nice slide that my friend Marie-Claude Maurice put together, and I love to repeat this slide because that shows our reality, our day-to-day practice. And again, this is the rationale. And again, I have to give credit to Biosensors, to Phil Urban and Marie-Claude that helped us to put together this study. This was the very first study that designed a short depth versus prolonged depth after BioFreedom, after a polymer-free stent. And as you can see here, there was when we compared bare metal stent with BioFreedom, which is a drug-eluting stent with no polymer, you can clearly see that there was a reduction in terms of target lesion revascularization, half, 10 versus 5%. Also, in terms of safety, there was a reduction in cardiac death, MI, and stent thrombosis, 13 versus 9.4. But we didn't have to pay a price for bleeding because remember, we stopped doing antiplatelet therapy, clopidogrel, most of the cases in 30 days. So this was a very pioneer study. After that, you see the replication of this study with Onyx, with Xience, and many other stents, new generation stents. But we need to give credit to the very first stent trial. And again, for the US approval of BioFreedom, there was a registry of 1,200 patients compared with the historical BioFreedom 1 bare metal platform, as you can see here, which is supposed to be the gold standard for safety. So with this matched comparison, you see the replication of Leaders Free 1, which was again 12% for the metallic platform with no drug, versus 8.6 for BioFreedom. And again, with not only a non-inferiority margin, but also with superiority for BioFreedom versus the metallic stent, bare metal. The same thing you can observe here for the efficacy endpoint. So there was a reduction in restenosis from 9 to 6%. So doesn't go any further. So this is my final slide, just to say that high risk for bleeding and low risk for ischemic events. We should aim for short depth if you want to see less bleeding, but with no compromise in ischemic events. Low risk for bleeding and high risk for ischemic events. Then you have to think about prolonged depth. So when there is a young patient with no previous history of bleeding or no other predictor of bleeding, and this patient comes with a ST elevation in MI, multivessel disease, bifurcation, diabetes, then it's okay to give prolonged depth. That's what we do, and that's what most of the guidelines will suggest. And finally, the new generation polymer-free DS certainly represent a safe alternative for patients with high risk for bleeding after PCI, when you really have to prescribe 1 to 3 months of dual antiplatelet therapy. I think that I finish on time and I'm open for questions. Thank you again for the opportunity.
Thanks, Alex. That was a great summary of what is certainly a very complex topic. And of course, it's become even more complex in the last few years with studies of for instance, with ticagrelor monotherapy rather than aspirin-based monotherapy and after PCI. So let me just ask you a couple of questions. So obviously you'll be very familiar with the HBR criteria. So following on from Leaders Free and some other studies, the Academic Research Consortium, which has defined various endpoints for stent thrombosis, for instance, was the first one, and they've also worked on TAVI outcomes. They've defined the parameters, major and minor criteria for identifying patients at high bleeding risk. And one of the surprising things is how many patients meet these criteria. So last week in Eurointervention, for instance, there was a study from Japan where 50% of the PCI patients were high bleeding risk. I just wonder what you think that and I'd like to ask the opinions of the other speakers. Do you think it's as high as that in Brazil or in Russia or in Latvia, for instance?
Yeah, so I'll give you my very quick answer, because of course we give opportunity to the other colleagues. But I think it's a little bit too much, Keith. I agree that we should have consensus, because any study or every study will have a different criteria which maxes up our mindset and our results. For instance, the precise criteria is a little bit different. One thing that I think that we are right is not because the patient has 70 or 75 years old, he's high risk for bleeding. We learned there is very rigid and not frail elderly patients. So I think that we are a little bit too much in terms, it's certainly not 50%, but I would say that at least 1/4 of our patients, around 25% that we treat, those are the patients that we debate whether we should give shortened depth. But again, I think it's a little bit perhaps a overreaction of this criteria that is a little bit too much. I want to see what the other opinions.
Yeah, if I can, I guess it's really a nice point.
I would love to say also that in our clinical practice, of course, we use HBR criteria, and I totally agree with Alexander that these are aged patients. These are patients with antiplatelet therapy, the patients with atrial fibrillation after TAVI. But we do not meet these patients that often. I think it's about 20 to 30%. So I agree with Dr. Alexander. I would say, yes, this is the proportion of these patients. But we also should differ patients that are stable and patients that come with acute coronary syndrome. The patients with acute coronary syndrome are problematic patients. And I think that case that we will consider next will give us a very good picture. If we talk about Japan, I would believe that they have this high percentage of patients with high bleeding risk, because we should remember this is one of most aged nations, and they have lots of patients who are older than 75. And the higher is the age, the more complications we have. So I think that the Japanese were not unfair talking about each second patients with high bleeding risk. In Russia, I agree with the previous speakers, we would have 20 to 25 patients. Well, in general, in the world, we have more patients 80 plus because people live longer. Yeah, world population is aging population. But this is more about more well-off countries.
Yeah.
Andres.
Yeah, thank you. I guess it was fantastic point, and what Rose and Keith and said, and what you answered to. And I also think that maybe we need a bit to simplify it. But of course, we should not to make really simple this criteria. But I agree that it should be a bit simplified. And that's also we've seen from MI definitions and other things. And of course, I guess it's a great point, because actually we have now a completely different world, because we are doing so many other procedures for our patients. And then sometimes before, not sometimes, but very usual, before TAVI's procedures, we do a lot of things. Also, as you mentioned, our patients are becoming older, but this is, I guess, it's very important that it doesn't mean that age. I'm not sure that only age is predictor, because what we really see is that our population is much more healthy even in 80 plus years. And for example, in Latvia, in last 20 years, we had doubled population of 80 plus patients. Oh, I mean, we all have potential patients, but I mean population. That's why I completely agree that we need maybe go for more simple criteria. But on the other hand, of course, I also agree that there is some 20-25%, maybe less. It's very difficult to say. Our patients who need really to consider it, what we should do yeah.
So just to try and keep to time, so we're going to move on now to an HBR case presentation by Dr. Shugashev. So Dr. Shugashev, the floor is yours.
I hope you see my slides.
Yeah.
Слайды на русском.
Slides are in Russian.
Но надо будет перевести на английский.
I still don't understand what language should we use. We will have some slides in English, some slides in Russian, so I hope that you will understand me. So, PCI patient with high bleeding risk, my philosophy. Of course, if we talk about risk factors, age, comorbidities, certain blood states, drugs, previous vessel complications, or transfusions. The PCI was already, the definition was already used. It is consensus that defined the high bleeding risk in patients after PCI. And also these studies were already demonstrated, dubbed precise diet and global leaders that made the basis for the scientific definition of the patients with high bleeding risk. So what is high bleeding risk? The high bleeding risk means that there is risk that during the first year, the patient will have bark bleeding. Bark scale have a few subtypes, and the third type are all the major bleedings. The fourth type is rarely associated with cabbage. So we are interested in all the types of third type of bark during the first year, if there is risk of intracranial bleeding. We consider these patients as patients with high risk. How to define a high or low risk? If we have at least one major criteria or two minor criteria, this patient is high bleeding risk. As for major criteria, we keep in mind antiplatelet therapies, low hemoglobin, and depending on different characteristics of patient's health, we can define high bleeding risk on the initial stage and what category of patients this patient belongs to. My philosophy is quite simple. As it was said already, we should not forget about unstable patients. All the patients are stable and unstable, and it is very straightforward. If the patient is stable with high bleeding risk, we decrease the APT. If the patient is with acute coronary syndrome, we try to decrease risk of ischemic complications, and we should be more cautious here about decreased DAPT. In the chart, you see the standards of the American College of Cardiology. They do not differ significantly, but Americans more decrease DAPT depending on the process and depending on the stents implanted. The clinical example, the patient is 58, he had MI and he had arterial hypertension, persistent atrial fibrillation, peripheral arteriosclerosis, decreased renal function, and according to angiography, left coronary artery without particularities. But though we do not see obvious lesions, we see in left main calcification. That means that the patient has serious lesion of coronary bed. The patient, during catheterization of right coronary artery, we see recanalized thrombosis. The patient earlier had myocardial infarction in right coronary artery, 3 biometrics stents that proved first the efficiency in patients with high bleeding risk. The particularity of this patient is that he has a very complicated osteum of right coronary artery, and the multivectorial imaging didn't give us clear answer where the opening, where the osteum is. IVUS. My philosophy would not exist without IVUS. IVUS was performed before the stent implantation and after the stent implantation. Before the implantation, we found the Leiden zones. That is important for HPR patients because we understand that good implantation decreases the risk of thrombotic complications and increases the chance to quitting of disaggregant therapy. And we see here that the stent is well positioned under the ostium of RCI. The certain part of stent is in aorta, though his biggest part is near the wall, and I think that only intravasal imaging allows to position the stent with high precision. And thus we avoid thrombotic complications. You see that in this patient we have renal dysfunction, he has anemia, and patient with atrial fibrillation was taken long-term RNOIK. If we tackle guidelines, we see that for this patient, we need to use modern anticoagulants, and the patient is the candidate for whole life antiplatelet therapy. The question is what to do after stenting. Ticagrelor or prasugrel are not recommended. We can use only clopidogrel. So the question is, should triple therapy for short period or dual therapy with modern blocker P2012 and remove aspirin? And in our philosophy, we use modern imaging methods, IVUS, OCT, IFR, or FFR. If we are sure that the stent is implanted correctly, if we can perform follow-up in short term. In this situation, we will prescribe long-term dual therapy, and we will be sure that the risk of bleeding is decreased. If we have only traditional angiography, then we will prescribe triple therapy for short term, and then we will switch to dual or monotherapy. As we have patients with chronic coronary syndrome. Here is a female unstable. She has comorbidities. It's different to say what is the main disease here. She has cancer T3 and 2MO diagnosed in September 2019. And she's also a smoker. This patient is a smoker. And she is with acute coronary syndrome. On crusade scale, she got 42. On angiography, we saw acute occlusion of circumflex artery and stenosis of anterior descending artery. Using the definition of HPR, we saw that the patient has only one factor that can provoke bleeding. It is active cancer. So the patient has 42 bleeding score, but we do not have any specific scale for STEMI, for risk assessment. Step by step, what treatment should we choose? In 2020, we take aspirin and prasugrel or ticagrelor in these patients while they are inpatient. Clopidogrel is nearly forgotten in this category of the patients because it is proven that statistically significant ischemic events decrease major bleeding that are non-cabbage are equal in prasugrel and clopidogrel. As for ticagrelor, we shouldn't forget that it is one of most important drugs for unstable patients. This is a great, though old, trial plotter that demonstrates that on cumulative effects, ticagrelor is better. We also remember that all the endpoints were to the favor of ticagrelor, and we also remember that the stronger is the drug, the higher is the bleeding risk. But Plato demonstrates that the number of major bleeding does not differ in ticagrelor and clopidogrel. And we should not forget about it, of course. Now we compare ticagrelor and prasugrel. And this is a famous study, ICER REACT, that was kind of shock for our society. It turned out that prasugrel is safer and more efficient than ticagrelor. Though this study is criticized still, it is not very literally designed. And in my philosophy, I would say that I do not use the data of this study. I don't see that this is a very robust result, and I cannot use it in everyday clinical practice. Not only efficiency, but safety of prasugrel was higher than ticagrelor. So for this patient, we prescribe aspirin and ticagrelor. Then we decide on stents. Of course, today it is only drug-eluting stent, only the modern last generation stent. Bare metal stents are already history, in my opinion. This slide was already demonstrated. The new generation stent are safer and more efficient in most of the patients. Short day PT, we have 4 studies, 4 trials that evaluated short-term day PT, especially if we talk about LEADERS 3, where we had more than 2,000 patients of high risk, and we see good safety, good efficiency, then there was patients who were where trials where bare metal stent compared to DAS, and these are Synergy, Endeavor, and Everolimus. So we choose, of course, only new generation DES. Here is the final result. We used Everolimus eluting stent. The patient, after the intervention, then stenting of LCA was performed, and of left anterior descending artery was stenting performed, and you see the final result. Step by step, post-interventional therapy. This patient is a patient of high bleeding risk, and according to all the guidelines in 2020, these are the first guidelines that had a special group of patients as patients with HBR. The patient is recommended aspirin and clopidogrel during 3 months and switching to aspirin monotherapy. We use precise depth scale to evaluate short-term treatment, and we see that the patient, if the patient has the score more than 25, we can prescribe short therapy. So today in our lab, we have the philosophy that is very simple. Radical procedure. We try to choose patients during 1 month. I know that my colleagues also use IVOS and angiography. After 1 month, we always perform OCT control, and if we have optimal endothelialization, then we discuss discontinuation of DPT and prescription of monotherapy in patients with high bleeding risk. Today, I can say that in our philosophy of this complicated patients, we do not see how to treat them without modern methods that demonstrate the stent implantation and decrease of ischemic events. And as time passes, we can evaluate ischemic situation, stent endothelialization, and in our lab, thankfully, we do not have procedures without intravascular technologies. Thank you for your kind attention. I hope I was on time as well.
Great. Well, thanks. That's quite a provocative presentation with 2 really interesting complex cases. So I guess what you're saying is that you're using intravascular imaging at the time of the implantation to improve the outcome of the procedure, make it safer to go with either short DAPT or even single antiplatelet therapy with an anticoagulant. And then you also have a strategy where in some patients you re-image using OCT at 1 month before stopping DAPT. So, I mean, those are complex strategies, and I don't know if anybody on the panel would like to comment on how widely employed that sort of strategy is. You know, Andreas, do you think you can shorten the DAPT if you use if you go with a intravascular imaging to optimize the stent implantation?
Absolutely, you know, that actually we do around 20 years IVOS and then 15 OCT, but I guess you are right. For example, if we are having in our institution 4,500 PCIs, and if we, you know, counted that there's a 25% of patients with high bleeding risk, then that means that we should use around 1,000 cases with or a bit more different kind of intravascular intravascular images. Actually, it's my philosophy, and I started in 1990, and of course I completely agree. But I guess that if you do around 10 to 15%, or maybe 10, of course we want to go for higher numbers, but if you do around 10 to 15% of intravascular images, then from all pools, then actually you are getting what we call like this imaging eye. And then of course maybe we can decrease in each procedure, but what we really do in our center, that we really use, and we try of course to do appropriate sizing, and this is a very important. Of course, the appropriate sizing is one thing, but what we really do, we practically, I guess it's 95 or 97% of real pre-treatment and post-treatment. And post-treatment is non-compliant balloon for better symmetry index, and not only, and also to reach media to media criteria. Of course, it's not always easy, but as I says that in future, I am completely agree. I'm not so agree that we need to if we have a good result. I'm not so sure that we need then to check maybe a to do some follow-up with imaging. Of course, we do. We are participating in many studies and for scaffolding and other things. But I'm completely agreed that of course it could help. I'm not sure that it is possible in real life everywhere.
Sure. So you basically you've taught yourself, having used intravascular ultrasound and OCT for so long, you've taught yourself really what a good result is, and you don't actually need to do it in every case to avoid undersizing and underexpansion.
Absolutely.
Yeah.
Yeah.
Okay,
Yes.
great. Thanks. So we are just a little bit behind time, so we're going to move on, and I'm delighted to introduce Dejan.
There is a quick question. Question.
Yeah.
I wanted to ask Professor Shugushev about this time. You mean months? Of course, it's okay if this patient is with cancer. I understand why you speak about 1 month, but why do you have this 1 month? Usually, we have mature endothelium in 3-4 months. 1 month gives us only very immature endothelium. You can scratch this new endothelium with your guide. Would you increase the risk? Thank you for this question. Yes, this case is exclusive, and this is the situation when the patient is under death and life situation due to the main disease. And of course, we do not perform only catheterization. We here to see if the stent positioning is good, especially if we see that there is no big gaps in vessel wall, then we can recommend this patient together with oncologist, with cardiologist. We had 3 such patients, and thanks God, nobody had any thrombotic or hemorrhagic complication. So for us, it was important to control the stent apposition after 1 month.
Description. So it's quite a relatively unusual situation, I guess, when somebody with left main PCI needs to have their DAPT stopped at quite short notice. Any other questions at all? Okay, great. So now I'm delighted to introduce Dejan Milisinovic from Belgrade in Serbia, who's going to talk to us about the potential advantages of biolimus in patients with acute coronary syndromes. Over to you, Dejan.
Can you hear me all? I hope that you can hear me and that you see my slides. First of all, I am delighted and privileged to be here with you. It is a great summit with a discussion of really important and pertinent topics in interventional cardiology. So I'm grateful to the organizers for the invitation. And the topic that I will be discussing today is the acute coronary syndromes and perhaps a potential hypothesis how we can improve outcomes in these patients. So these are my conflicts, and this is the outline for today, and it bears down to basically two very simple questions. So is there something new in 2021 regarding the treatment of patients with acute coronary syndromes, which are the bread and butter of our profession, more or less? These patients have a clear indication for PCI, and nowadays this becomes important in terms of post-ischemia interventional world. And the second question is, how could we improve the outcomes in this patient group? So we go to the first question, and at least in my humble opinion, what really changed in the past year is that we had in 2019 the release of the complete trial data, and I will try to show how I think this will change our practice in ACS patients. Just for a reminder, for those who are not familiar with the design, this was a large study, 4,000 STEMI patients with at least one significant non-culprit lesion who were randomized to either PCI of only the culprit lesion or PCI of all significant lesions. And what was looked at finally was at a median of 3 years, death or MI. So really a solid hard endpoint. Now, what are these patients actually? I think this is important to be noticed. So FFR was used basically in less than 1% of patients. So these are really the everyday practice patients that we are going to see. So decision whether there was a non-culprit lesion or not that is significant was based practically solely on angiography. So if there was a more than 70% lesion on angiography, this was considered to be a multivessel disease, apart from, of course, the culprit lesion responsible for the STEMI. And these were the results. And I think this was important because you see here a clear separation of the Kaplan-Meier curves in terms of better results associated with the complete revascularization. A second point that is important in this respect is that the curves seem, at least to me, to be separating. And if you look at the percentages, it's roughly around 8% in the complete revascularization group and roughly about 11% in the culprit lesion only PCI group. What really made a difference was actually the occurrence of new MI. So basically, if you did not treat the non-culprit lesions, angiographically significant non-culprit lesions in this trial, you basically risked a higher rate of new MI in these patients. Now, the question is, how can this be explained? Because this is basically the first study that really had the hard endpoint of new myocardial infarction and cardiac death in favor of complete revascularization. And this may be in part the explanation. This was published just last year, also in the data set of complete trial patients, where the OCT interrogation in these patients actually showed that if you had an obstructive lesion on angiography, in at least 50% of those patients, you on OCT had TICFA, that means thin calf fibroatheroma, which is at least considered to be vulnerable to and bearing a high risk of new MI. So this is how potentially the positive results of PCI for all angiographically appearing significant lesions could be explained by this sub-study showing that basically in at least 50% of those patients, those plaques were lipid-rich plaques. Now, why is this important? This was just a reminder for a study that I think is wide known. So how does this change our practice? Well, at least to me, this seems to be that we may be on our way to implanting more stents. And if you hear about stable patients and ischemia trial, you think less stents. And quite on the opposite side, the complete trial may be suggesting that we may be implanting more stents in the future, at least in patients presenting with the acute coronary syndrome. And this, by extension, would mean that we would have more complex PCI as well. So what I will show you is a patient that we had 2 years ago presenting with acute coronary syndrome. And this patient basically had a 3-vessel disease. And we decided to go with the percutaneous intervention. The patient was turned down by the surgical colleagues due to advanced age. And this is something which we see more and more often. So this, I think, patient demonstrates clearly what was shown previously. So we have culprit lesions, and you don't really need, and non-culprit lesions as well, but you don't really need OCT here to tell you that most of these lesions are basically probably unstable lesions. You see they are pretty tight and also hazy on angiography, so you would not need the OCT substudy of the culprit child to tell you that these are probably lipid-rich plaques in this patient. So we treated a patient with a long DES in the RCA and the obtuse marginal branch, and then we proceeded with a top standing of the left main. So we placed the crossover stent to the LAD, and then you see here the ostium of the circumflex we were not happy with the results, and we did POT, and after POT the result was still not the way we wanted, so we implanted another stent in the circumflex, creating a short metallic neocarina, and what we finished off was the final kissing balloon inflation with a short overlap at the polygon of confluence. Now, we followed up this patient, and this is the ACS patient with several lesions, so treated with several stents. Altogether 2 long stents and 2 stents in the left main for top. And in 2-year follow-up, this patient was without MACE. So now there is this question: how do we deal with these ACS patients? And is there anything that we can improve in the treatment of the ACS patients that will more and more require complex PCI and more stents? And we know that multivessel PCI, the rate of multivessel PCI or the multivessel disease in patients with ACS is with STEMI at least is 40 to 50%. So every other patient presenting with STEMI would require a multivessel PCI according to that. So we know from the PROSPECT trial, and this is 2011, New England Journal of Medicine, that if we follow up the patient that I just showed you, half of the events that we expect are going to be thrombotic are going to be related to the stent related, and the other half would not be related to the stents. And this is the PROSPECT trial showing you that you would expect that at least half of your events are going to be stent related. Now, it would be, of course, interesting to see whether this rate, this percentage would change in the contemporary practice of post-complete everyday interventions, where we practice perhaps more PCI than we did at the time of PROSPECT, now that you would treat many non-culprit lesions with PCI as well. We don't, of course, have the data, so we for now think that at least 50% of our patients would have stent-related thrombotic complications after being treated with percutaneous coronary intervention for an ACS. So the second question that we have today is how can we improve the treatment of ACS? And if we say, okay, it's 50% is related to the stent of these ischemic complications, is there anything that we can do regarding the stent choice that matters? And there are 3 traditional components of the stents that we have, and we could try and see whether any change in these components could impact our clinical outcomes, which is ultimately important for both us and the patients. And of course, we could look at the stent design, and there are trials like BioFlow showing that perhaps the thinner strated stents could improve outcomes. There are also the second component regarding the polymer, where we have durable versus biodegradable or even polymer-free strands like BioFreedom stent. And then we have the drug, which is the third component. And the hypothesis that may be advanced is that by changing, by having different drugs, that maybe the outcomes could be changed of patients. This is, of course, a very bold hypothesis, and we will see that there is some data, but I would not say that there is definite data on this. But it's interesting to think about it at least. So what we know, and this is, I think, very relevant meta-analysis, just came out last year, 2020, showing the trends, and this is from New York, actually, the group that published it. And I actually found it very interesting because it clearly shows you 2 things. First, what is it that we're looking at? So these are randomized trials which compared BMS, bare metal stents, with the first and second generation drug-eluting stents in contemporary everyday practice, so all comer patients. So what we look at is target lesion failure, so basically stent-related events. This is what is of interest to us for this presentation. And we see that there's a clear difference in the effects or in the outcomes that you have before and after the landmark of 12 months. So in the first part, and this is on the left-hand part of this figure, is the first year following the intervention. And you see in this very large cohort of patients that the outcomes, the stent-related events with the BMS is by far occurring more frequently than with the first or the second generation DS, which is what we expect. What was interesting to me is this second part of the slide, and this is on the right-hand part of the figure, where you actually see that the curves are more closer to each other. You clearly see basically that the red curve, which is the first generation DS, fare worse than the BMS or the second generation does after the 12-month landmark. And the second information that we gain from this figure, which I think is important for our practice, is there is no plateau. So the stent-related events will just continue, and you see at the title of this slide at the rate of approximately 2% annually. So what we need to know is that in our everyday practice and in our ACS patients, even accentuated even more, we will have to face the challenge of stent-related events over time. And it will not stop at 12 months landmark, it will continue, and the rate seems to, at least in the contemporary practice, be 2% per year. So can we do anything about the stent choice that could affect the outcomes? In my humble opinion, what perhaps matters more is the technique of stent implantation, but we should also not neglect the data that we have in the different stent comparison trials that may also suggest some novel findings there. So what I'm going to present you in the next 3 or 4 slides, and with that I will conclude, are some of the findings that I think are worth at least looking at regarding the stent choice. So if we go to a study published in 2008, LEADER study, which compared the second generation biometrics stent with the Cypher stent, which is a first generation stent, and which elutes sirolimus, as opposed to biometrics, which elutes biolimus, you basically see a differential effect. And this is a forest plot, a very complicated graph, which I do not want to go into details here. What you should look at is these squares, the black squares. They're all grouped around the central axis, only not in the one subgroup of patients, and these are the STEMI patients, where you clearly see that there is a differential impact, that the black square is on the left side favoring biometrics, which is different when you compare it to other black squares in other subgroups. And if you look at the interaction point in 0.020, so it does statistically show you that what you optically see as different, in statistical terms, really is different. There seems to be a differential impact of biometric versus Cypher in this unstable group of patients. So this is the first piece of evidence. If you follow up this particular group of patients, so STEMI patients from the LEADER study at 5 years, you basically you can record that there is a difference in thrombotic events, even in cardiac death. And this is statistically significant. So you can say, well, if I compare the second generation biometric stent with the first generation Cypher stent in the subgroup of patients presenting with the acute coronary syndrome, there is obviously a difference in thrombotic events. And this is something which is not surprising to us. And we also saw in this meta-analysis, this is something which can be expected when you compare second generation with the first generation DES. Now, this is the second study, which I find even more interesting. And this is actually one of the 3 trials that I'm aware of that are actually considered to be large landmark trials, showing better effects of DES in general as opposed to BMS in STEMI patients. These trials are examination trial with the everolimus eluting stents versus a comparator BMS, a comfortable AMI the trial that I will introduce now, which is biometrics DES versus a comparator BMS. And the third trial is a master study, a master trial published a few years ago, comparing the Ultimaster stent with the comparator BMS. So these are 3 trials that compared DES versus BMS, and all were basically positive trials in terms of favoring the DES versus BMS in patients presenting with ST elevation myocardial infarction. What is interesting here is that you can basically dissect the different components of the stent, because you have the same stent platform in this study, and the similar was in the other 2 studies that I mentioned. You have the same stent platform for BMS, only with the addition of the drug in the DES arm. And if you compare those two stents in a population of STEMI patients. And what I show you here are 5 years outcomes of comfortable AMI. You basically have a statistically significant difference in terms of hard endpoints like myocardial infarction at 5 years in favor of biometrics compared to the bare metal stent. So you can basically conclude, and this is something which we know from the literature, then in STEMI patients, DS probably should be preferred, and this is confirmed here. And the third piece of evidence that we have for this interesting hypothesis of bioluminos is that in the LEADERS-3 trial, which is the most recent and probably the most actual of the trials that I showed you, we showed a drug-coated stent, so a stent without a polymer, unlike biometrics stent that has polymer, which biodegrades, which disappears in 6 to 9 months. Here with the DCS, we do not have polymer at all. Here we have only the bioluminos drug, which goes from the stent surface on into the cells after the implantation. And here in this study, if you look into the ACS subgroup of patients, and these were HBR patients with specifically the ACS subgroup, you see that the effects are potentiated. And this is the difference in the thrombotic events, once again, cardiac death, myocardial infarction, stent thrombosis. And you see the effects of the bioluminos-eluting biofreedom stent that are potentiated in the subgroup of ACS patients. So taking all together, I think that three interesting statements could be made. First, we seem to be moving towards the goal of complete revascularization in patients with ACS. And since almost a half of ACS and STEMI patients are going to be multivessel patients, this could mean that in the future, this is an area where we are going to be implanting more stents. And with the increasing age of our population, it is likely that these are going to be more and more complex PCIs utilizing more stents. Secondly, that being said, we need to be aware that at least 50% of our unwanted adverse events throughout the follow-up will be related to the stents that we implant. So there are two variables that we can know to impact the outcomes related to the stent. One is the stent choice, and the second is the stent implantation technique. And I think both are worth looking at and worth improving in. And the third is this interesting bioluminos hypothesis, where we could see in 3 different trials with the bioluminos-eluting stent with biometrics and biofreedom from the LEADERS study, LEADERS-3 study, and the comfortable AMI study, that there seems to be, at least from the data shown, some sort of a differential impact with the effects of the bioluminos-eluting stent potentiated in patients presenting with the acute lesions with acute coronary syndromes. Thank you very much for your time, and I hope I did not overstep the time.
That's great, Dejan. Very clear presentation. And of course, from my own perspective, the results of COMPLETE are very interesting, because I'm sure some of you will remember that we published the PRAMI trial a long time ago in 2013 in the New England Journal of Medicine, showing that angiographically guided complete revascularization in STEMI patients with multivessel disease improved their outcome against standard of care. And frankly, nobody believed it. And there were a lot of skeptics about the result of PRAMI, and we were pleased when eventually COMPLETE confirmed the result. And of course, the outcome, the clinical outcomes that you showed for target lesion failure rate, that's a lesion level. If you look at target vessel failure, that will be even higher.
Exactly.
And if you look at complete repeat revascularization at a patient level, that's even higher. So there is a lot of discussion about, well, stent design is as good as it can be, and maybe there's nothing else we can do. But I think most of us don't believe that, and we definitely need some improved outcomes with the stents that we use. And you've given us some thoughts about how we might achieve that. So any comments from the other panelists?
Okay, just one question from Russian audience to Dejan. Dejan, the question is, what was the reason for choosing Cypher as comparator stent in LEADERS trial?
I think the reason, in my humble opinion, was seen in the reference, namely the year of publication, which is 2008. So I think at that time, it was the Cypher was basically called was used at the time of the recruitment for the leaders trial. I think the cipher was used in everyday practice, and this was the reason why this next generation DS was compared with cipher.
And they have the same near thickness, 130 in biomatrix and 140 for cipher.
They are thick stratis stents. So this is the thing that I think we need to separate. So this is why I tried to show this in the slide. There are three components of stents that we can actually work on. So when you have when you have trials comparing different stents, I think it is important to keep in mind that you're not looking at one variable, that you need to be aware of these three different variables: stent design, which is mostly stud thickness, but also the open cell or closed cell design, and so on, and the way the stents are manufactured, because not all stents are just manufactured are the slotted tubes. Some of them are interwoven. So basically, you look at the stent design, and then you have to look at the polymer, whether there is a polymer or not, and then you look at the drug. So I think it is important not to confuse all these three different components when you try to compare the stents. And this is why I think those three trials that I mentioned, Examine, Master, and Comfortable AMI, are very interesting, because they basically used their own comparator BMS to compare it to a DS stent. So you basically have the same stent platform. What you add is the polymer and the drug, and then you compare it in the STEMI setting, and you clearly show that DS is better. So I think these trials are neat, and they are actually, for me, very educative.
Thank you for explanation. And one short question for me: have we any free time, Kate, or we have no time behind?
No, on you go. Let's have a question.
Okay, only short question about drug-coated stent.
Mm-hmm.
This stent gives a lot of hopes, personally for me, about its efficacy, and particular for shortening of doubt, in particular the high bleeding risk patient. But after sort out 9 trials where DCS did not meet non-inferiority when directly compared to Orsiro, ultra thin DES, what is your position, and what would be a future this technology, and in particular the stents, in terms of ACS patient?
Well, I think that's a very interesting question. And my comment to that would be the following. If you observe the Onyx 1 trial, which is the latest trial in this field, you basically see in both groups of patients with both stents an increased rate of stent thrombosis that you would expect it. And then there is very new data from January 2021, published in JAMA actually, from the group that initiated the Leaders 3 trial. And I think there are people here who can comment more on this than me, but showing basically that in an HBR population, you also have an increased risk of thrombotic events. So this is something which I think needs to be talked about. And this is something which we need to be acutely aware about. So if you have an HBR patient, a patient with high bleeding risk, chances are pretty high that this particular patient will also have an increased thrombotic risk. So what you would need to do basically is try, if possible, to really pin down what makes the patient the high bleeding patient, or what makes him a high ischemic risk patient. And in this publication in JAMA from January this year, there are 4 sets of variables in each of the groups. Those variables related only to high bleeding, like for example, cancer or liver problems. And then there are those groups of variables related only to ischemic events, such as complex PCI, with the long overlapping stents, or a 2-stent bifurcation PCI. And then there are variables that are in the middle, related to both bleeding and ischemia, such as, for example, renal failure. So I think that we will need to do more research to really pinning down and identifying what makes a patient a high bleeding risk, or a high ischemic risk, or a combined. I don't think that we should be blind and say this is a HBR patient, so let's forget about thrombotic risks. We should not do that. So what I think is that the real test of time for all these stents will be how they fare in complex PCI in HBR. So having both complex PCI and HBR, and you would need to have an option, stopping after 1 month and then maybe continuing after a few months with the DAPT after this period of high bleeding risk has passed, because this is also possible. The bleeding risks change over time, and it is important to follow up the patients and reassess the risk of bleeding at some time point, because it can change. So what is, I think, important, it is important to have a stent which has good outcomes with complex PCI, and that gives you an option of really short DAPT. But this does not mean that forever it's going to be a short DAPT. It's only an option of short DAPT, but you need to have data that this particular stent is also good for complex PCI.
Yeah, I just expand just a little bit on this. So for SORT-OUT 9 was all comers patients. And actually, it's remarkable how well the biofreedom performed against Elcyro in SORT-OUT 9. And although it just missed non-inferiority, that was driven by repeat revascularization, not by cardiac death or by myocardial infarction. In fact, there was an absolute 1% reduction in cardiac death in favor of biofreedom. And again, in RNOIK 1, it was again quite remarkable how the 120 micron stainless steel strut stent with the BioLimus, how it performed so well against the Resolute Onyx, which is a much more modern design and thinner struts. And yet the event rates were identical. It wasn't just non-inferior, they were absolutely identical. Okay, so just we are running a little bit behind time. So if we could move on now, and I'd be very grateful if Akseli Sozakin, I think from St. Petersburg, could give the ACS case presentation.
Actually, I work in Moscow.
Okay.
I graduated from St. Peter University.
Apologies.
Well, I was very happy when I was student in St. Peter. I hope you see my presentation.
Yeah,
now I hope it's okay.
Now, yeah.
So I wanted to present our PCI complex case. You see, in the discussion, I have a question. What is complex case? What is PCI? How we decide whether it's complex case or not? Today, we do not have any formal criteria. What is complex PCI? And we have lots of calculation, syntax, Ever score, the calculator of the Society of Thoracic Surgery, but for formal criteria, we do not have any. I hope that soon professional society will create some terminology. Our clinical case is the patient, 63-year-old. In 2001, he had stented of circumflex artery. He had DES stent. At that time, it was the only DES. In 2003, he had stenting of right coronary artery with 3 DES. On admission, ejection fraction was okay. He had hypertension, very compliant patient. He follows all the prescriptions. During the previous 2 weeks, he felt deterioration of his feeling. He had angina in low effort. In angiography, we see that in circumflex artery stent is okay. There are good collaterals in distal segment of right coronary artery. Right coronary artery had low blood flow, and you see that in the distal segment of right coronary artery, there is retrograde blood flow, and I would love to draw your attention to the distal part of right coronary artery. In the edge on the sharp edge, and you see that contrast is going the bottom contour of stent. We tried to perform pre-dilation with regular 2.75 millimeter balloon. Then we continued in a more aggressive way. We performed a pre-dilation with higher pressure balloon 3 millimeters with a little bit better result. You see, we used left implants for support. We performed OCT to understand this problem, but OCT didn't help us a lot. We could not move the probe. We used higher pressure. We restored this part and we performed the OCT, control OCT, and we saw that in the distal artery segment, the OCT probe was in true lumen of the artery, but further it was going to the false channel above the surface of the stent that was placed 20 years ago. And here he was going back to the true lumen of the artery. On the A picture, you see with green arrows, we see this distal part of stent, and from 5 to 7 o'clock we are in the false lumen. There is no differentiation of the vessel wall layers. On the level, we see that there is certain space between distal part of the stent and not covered part, and up to the ostium of RCI. There is a good result for 18-year-old stenting. We thought that it is not quite everyday restenosis or stent thrombosis, and we thought that probably the reason was that it was on the acute margin of the heart, where sternal part goes to other part. And our colleague says that it's probably the implantation of this implantation made stent influencing the intima, evoking erosion, and probably this led to the occlusion of the artery. We performed the stenting on the whole length up to off. We used guide extensor with good overlapping, and the stenting was performed on the whole length. On the control OCT, we wanted to evaluate the position of the stent towards the previous stent. We wanted to check this problematic place. You see that there is a double contour. We thought that it probably dissection or intravessel hematoma. We see here two contours. But on OCT, we were disappointed. We tried 3 times to get the imaging of this part of the artery. And for the first time, I saw that before and after this point, we had this good image, but in the problematic area, we could not evaluate the artery. According to the stent assistance score, we saw that all the other parts of artery, the stent are positioned well, with no dissections, with no margin dissection, with good stent position. And here is one more positioning. And here, one more time, going back to the discussion about this case. It was one more time, we thought whether it was the initial stenting problem, Probably the doctor started stenting from proximal segment and then they went to distal segment. And it is important to understand this anatomic part where right coronary artery has this circumflex. We performed ultrasound without contrast. And on the ultrasound, we saw that in spite of our aggressive predilation, with the high pressure balloons, we achieved here only maximum 2.3 diameter of the artery. That is significantly lower than the reference point. And if you pay attention to the cross section, the predilation help us to deform the margins of the stent, but the whole stent body did not change at all. During the 20 years, stent became a calcified plaque with cap with good filling, and our dilation just moved the stent with this very aggressive recoiling. It didn't. It wasn't possible to reach these reference points. And one more time here on the big increase, you see this artery lumen. This is final angiogram. We had to stop here because we were afraid of, if we use a balloon with a bigger diameter, we were afraid of perforation of the artery. We were afraid of serious complications, and it would be difficult to manage such complications. And after this intervention, our patient becomes the patient of high bleeding risk. Here we will definitely need enhanced antiplatelet therapy. And it was very interesting to listen to the expert, meaning and what was the conclusion? We sometimes neglect the anatomy of heart, especially of right coronary artery, and the stenting with the short stents in the acute heart margin goes to diaphragmal part. And that shouldn't happen. We shouldn't use here short stents. I am all. It's all from my side. And I would love to listen to your opinion, dear colleagues. What would be your opinion in this case?
Okay, thanks. So it's a fascinating case and very interesting images. I guess you wired behind the stent on the second time, and then.
This is a very interesting case, but I think here we see two issues. Anatomy is important. Yes, that can happen, but I think that this can be a lower influence, but I think there are two issues. When you were going with the guide to placed, we evaluated. We should understand that this is one of the first generation. Yes, this is 2001. And first, when we put stent with a smaller diameter in the bigger artery, we want to put it all on this one stent. I speak now about myself. There is an operator's problem, operator's mistake. These are my mistake, for example. And if it is restenosis, if its diameter is smaller, the sheath goes outside. We goes outside, and then we go back. And when you perform this balloon angioplasty, then we just deform this stent. And I'm not sure that you were right about this hematoma. It's very difficult to cope with this hematoma. And the other issue is, and it is very important to know that here we look at today. If we talk about today, all these stents, I have kind of possibility of reserve, and the earlier stents, their compliance was lower, significantly low. And I think this is what led to this result. And I use a lot types of this imaging, and we compare it with ICT, with OCT, and in this particular case, we do not know whether we are right or not. What is the real dimension of the vessel? I would use ultrasound. It is really a big discussion here, but still it is one on the courses. With actually, in this particular case, probably that from inside we can see it better if we use ultrasound. This is just my comment. Thank you for your comment. The question was in general of understanding, because of course it would be great to go through the true lumen, but you see the angiogram, the contrast was going on above, so the kind of channel they appeared. If the patient did not deteriorate, we wouldn't have tackled. Well, there is nothing bad. I think you did it perfectly, very good. And it is a very complicated patient. You're absolutely right. It's difficult to say what is complex and what is not complex, because sometimes the A-class stenosis can become very complex angioplasty. And this kind of instant stenosis and instant occlusion are very difficult, really difficult. And we see that there are 20 years from the first stent implantation passed. I just, I don't like this full metal jacket. What do you think? Why did not we manage to get OCT here? I think that you deformed the stent, and he was just missed on OCT, kind of jump through the OCT. It's a kind of effect, stop-in effect, stomp in. It kind of stops and jumps. So, it was kind of jumping over on OCT. And this can happen very often. And you're absolutely right that it is quite difficult. So there, we need to do a lot of these balloons. And if there was huge calcification, we saw it. And if it is huge calcification, it's always more difficult. Mr. Babanashvili, what is your opinion? I thought it is a complex PCI that we really... your mic is off. Your mic is off, please.
Я говорю, мы вышли за время, у нас времени нет. Может быть, мы вернемся потом.
We're behind the schedule.
We're behind the schedule, I guess. but it's worth spending some time discussing these cases. I guess with a 20-year-old stent, that isn't in-stent restenosis. That's I think more correctly described as neoatherosclerosis.
Absolutely.
Of course, it is heavily calcified, and you almost always will go behind the stent struts, and I guess that's what happened at the start of that case. But ultimately, of course, you can still recanalize the vessel, as both of you said. It just becomes very complex PCI. Okay. So now we're going to ask Dr. Burhanishvili, definitely from Moscow this time, to show us a live in a box case with left main PCI with the biolimus stent. Thanks very much.
А как мне переключить здесь? Сейчас, секунду.
Just let's sort out technical issues. So I will speak in Russian. I don't need 40 minutes, don't worry. So this case is about a biolimus stent in the left main. I kind of, before the presentation of Andreas, and I think that Andreas used biometric stent. So the patient, man, 75, restenosis in stent in LAD and circumflexatory. We used distal radial access. It is our golden standard for all the patients, for all clinical situation. And there is acute. And we use 6 French introducer, 6 French sheath, 6 French sheath. And as for patient, here's a normal patient. No obesity, BMI 24, nothing specific as for organ situation, only prostate adenoma and nephrolithitis. And as for ECG, ejection fraction is normal. And we should mention the decrease, that there is a decrease of creatinine clearance. That is more or less okay. We see that there is risk factor, decreased renal function, and genetically predisposed thrombophilia. He has plasminogen gene polymorphism. I don't know how it influences on post-intervention treatment, but I decided to pay attention to this risk. He is former smoker, but he quitted smoking 5 years ago. And the 3rd class of effort angina. As for Euroscore risk 2.47 and syntax score 20. Medium risk for PCI. But if we talk about syntax score 2, we see that there is a recommendation for cabbage and for PCI. This is initial chronography, and here we see stents in the anterior artery, in proximal and distal segment, and in circumflexatory. And we see that there is critical narrowing. And here already we have stent, 2 stents. The different projection, right coronary artery, that was stented from ostium to the middle segment, 2 stents. And we have here restenosis in the middle segment of right coronary artery. Here is the angiogram, and we see here that 11 stents were implanted in different time. 2 stents in right coronary and others in left circulation, and 2 in circumflex artery. Where we started, we evaluated physiology and significance of restenosis in right coronary artery. And the focus is in stent. Hemodynamically, it is not significant. If we talk about in stent blood flow reserve and in distal, we do not see any hemodynamic significance of this in stent restenosis. So based on this physiology, we decided to use this, not to touch these 2 stents. This stent appeared to be insignificant, but when we measured IFR on distal part of stent, we see that it is decreased to 0.87. And here we see that before stent, that there is a margin restenosis of this stent. Now let's see pre-invention OCT. We had to dilate here. And we needed to adhere the OCT probe to get this good quality. We have here the dissection after balloon dilation and in stent restenosis, and neoatherosclerosis is seen here. There is fibrosis, no inthema. And what is important, stent does not reach the ostium of circumflex artery. We see ascending artery and ostium. So the stent does not reach the ostium 3 to 5 millimeters. As for the trunk, we see the diffuse lesion. We have a fibrocalcificated plaque with 90 micron cap. And this is the cross section. As for anterior artery, anterior descending artery, we see that we thought that it is not significant. We have a fibrotic neointima, and here we see that stent does not reach the ostium. Here is a part of the dissection that appeared after predilation of ostium of circumflex artery. And here are the arteries. It is free. What do we have here? Significant in-stent restenosis in LAD. We also have it in circumflex artery. A diffuse disease in the late mean, but there is no significant stenosis. And with a sufficient cross-section, it is a distal bifurcation stenosis 0.1, and the stents do not cover the ostium of LAD and circumflex artery. What should we do in this situation? Let's turn to the consensus of European Bifurcation Club. They recommend first to choose the stent technique on the individual, based on individual patient characteristics. But provisional stenting is the recommended technique for distal LM if not involving both branches. And this is exactly the situation. Only one branch is involved. We do not see the nervine in the other branch, though there was restenosis. So we can present it like this picture. So we understand that we need to stand this lesion going to the trunk. But what we can do with anterior descending artery? We decided not to use a drug-eluting balloon. I will not discuss it now, but we decided not to use it. We basing on the study RIPS 5 that demonstrates that drug-eluting stents are better than drug-eluting balloons. If we talk about long-term revascularization. So we decided to remove here this restenosis. So we need to implant the stent. We need to cover the whole old stent. But there is a very small site to ostium of LAD, not to go to the trunk. And here we have a very small uncovered site. It is very difficult to cover it. And there will be a residual site, residual area, where we will not have any drug-eluting stent. So we decided here to use two-stent technique. We decided to cover the stent LAD and circumflexatory. This is the positioning of biomatrix flex 4. The diameter was chosen according to the reference and optic coherent tomography. And these are certain remarks which reference points we use for full coverage. And here is the left valsalva, left sinus valsalva cusp that we use here. And we see that the trunk starts here, the same 3D reconstruction, and anatomically here is the commissure and the ostium. And here as we go from valsalva sinus to the ostium. And these pictures that I made for better demonstration, we have here high pressure balloon after the implantation of stent to circumflex, intermediary port. Afterwards, final kissing in LAT and final port in the trunk itself. So we have such culotte, KBT, proximal optimization, two biometric flex and biometric flex from LAD. What is the result? This is angiography. It can be very good result of stenosis. And what do we see on OCT? Here we have a good stent apposition, and we see it from circumflex artery to the trunk. We see that the trunk of artery and lower the stenosis are covered well, and the area of cross-section is 7.4 millimeters. It is good enough for good long-term result. Now from LAD to trunk, also a position as well. The cross-section is enough, and this is a confluence place, the place of bifurcation with LAD. So what we see here? We see here normal diameter, the position is good enough. And as for the whole positioning, Here is the aorta. We catch it in here. But nevertheless, we see the stent here that is going to 2 millimeters in aorta, but the ostium of the trunk is fully covered. And that's how we confirm the preciseness of the projection and the landmarks for stent implantation into the circumflex artery. This is a 3D reconstruction. We see from circumflex to the trunk and from LAD to the trunk. It is kind of overinflated design of the stent. It is kind of overextended. But all in all, we should not consider it a problem with stent. And we hear the ostium of LAD and the circumflex artery. It is well covered. And now the control physiology. We go through the circumflex artery. We see that there is enough of flow rate with different measurements. It is a little bit less in LAD, 0.94, but initially it was, if you remember, it was 0.87. Now it is 0.94. So we considered it to be a good result. If we check defined PCI, the level here is 0.95. 0.95 is a desirable level to reach stenting, as we see the significant result in long-term period in the patients who had good, better or worse IFR. And I would love to say that in this study, the residual ischemia is in both of these situations, the results were presented. And as for visualization, imaging of the stenting, we perform it always when we perform, when we stent. We use in our CAT lab one of imaging technique when we perform trunk stenting. And this is ultimate study that confirms IVORs. And we see that the difference between optimal and suboptimal PCI is quite significant, nearly 2 times in clinical practice. So based on this study, we of course use one of imaging technique. And physiology, of course, is very important here to evaluate the result, not only a hemodynamic technique, but also to evaluate the results of intervention. To conclude, there are 3 points. The first one about the functional evaluation of intracoronary imaging. It is important to perform it to make decisions on treatment of the patients and to evaluating of the assessment of the results. We would love to repeat that imaging is recommended when we perform interventions on the left main, because we need to achieve the optimal result, because angiographically it is not quite clear whether we achieved it or not. And the third point to discuss here, and probably Andres will join in, and all the participants, what do you think? What was better? Should we have put one more metal stent, or should we have used a DEB, or should we have put the second stent and getting good blood flow? that can give us a better clinical outcome regardless of metal amount in the artery. So it is kind of a challenging case.
Yeah,
so
very
that's
challenging case. I guess this patient's now got 13 stents. Started with 11, has now got 13. Maybe Dejan could comment. Andreas will comment shortly in his talk. Dejan, what do you think of that case? What would you have done in Serbia?
Yeah, it's very interesting case, of course. Many stents, and I guess this baseline imaging really helped, because you could see where the stents go up to, and you basically, as you showed on the drawing, have the problem if you would like to use drug-coated balloons. The question is, could you do a kissing balloon with drug-coated balloons? I am not sure, because then you have the part of the drug that goes beyond the carina. So that would be a problem, I think, for drug-coated balloons. Could you have positioned a drug-coated balloon just at the ostium of the circumflex? I'm not sure that that's so precisely possible, and you would have to protect the LAD, so you would have to do the kissing balloon, and inflating a kissing balloons at the polygon of confluence, even if you have a short overlap, would certainly jeopardize the intima in the left main. So I don't think that would be a safe strategy, at least in my opinion. So I think there is probably no way to avoid left main stenting there with such an ostial circumflex disease, at least in my opinion. So I think that the strategy that you chose is probably the one that I would have chosen as well, with one perhaps thought, and that is after the implantation of the circumflex stent in a crossover over the LAD. There, I think after the first pot, there could have been the first kissing as well with large balloons, non-compliant towards the circumflex and towards the LAD. And then I would have maybe tried to do an OCT run to see this gap, how wide it is, because there was this old stent in the LAD going very close to the ostium. So it would have been interesting to see how it looks. Maybe you would have been satisfied with that as well, and then you could have avoided the second stent across the LAD. But I'm not sure, of course. You cannot know. That's only one thought. After implanting the second stent is a Collot strategy. I think you showed really excellent results with the OCT. So expansion and the up position was really great. I did not see any levels of malapposition or any underexpansion, so it was really great. What would be interesting, but this is maybe only of academic interest to me, would be the length of neocarina. And you could do this with 3D OCT reconstruction. With the OCT run, you could really see what is the length of the neocarina, because this depends on the rewiring, the place of the rewiring. If you rewire after placing the circumflex stent, when you rewire towards the LAD, the length of neocarina will be determined by the position of rewiring. If you rewire distally through the distal struts, you will keep the neocarina, the metallic neocarina, really short. But sometimes you cannot control that, because it also depends where the links of the stent struts are. But it's, I think, an interesting variable to know. So when we do Collot in the left main stenting, this is something which we look at. We look to reduce the length of the neocarina as much as possible. So that's maybe one comment, because then the final pot will depend on that as well. Because if you have a longer metallic neocarina, you can crush it with a too deep pot. So basically the final pot after Collot stenting should be shorter. And if you know how long the metallic neocarina is after doing OCT, for example, then you also know how to orient with this final pot. And maybe the last comment is the final pot could even be avoided, and that's only my humble opinion, if you keep the overlap of the kissing balloons, the final kissing balloon. So the last kissing balloon is very short. So if you keep your kissing balloons, if you end at the polygon of confluence, then you see also with the imaging that you dilate and you have a really good apposition at the polygon of confluence, and you do not create this bottleneck effect that you create with the longer overlap. So if there is a short overlap of the kissing balloons and the first pot was adequate, then you would probably not even need the second pot. So those were some of the comments, but really great case. I mean, the OCT showed really beautiful expansion and apposition of the stent struts and a complex situation. So really interesting. Thank you very much for showing this.
Yeah, just a question about physiology. 094, for your opinion, is quite enough for defining these results of PCI like as acceptable or not, because we know that 0.9 is quite enough in cutting level for IFR. But according to defined PCI, there's a new marker, a new level of this marker, 0.95. What about you? What is your opinion? 0.94.
So it's a really interesting question, and I will try to be as brief as possible. The problem with the left main and physiology is that you have a lot of downstream disease very often. So basically, when you correct the left main beautifully as you did, you cannot exclude the downstream disease. So the values that you get with physiology and the left main will very much depend on how the downstream disease is. That's one point. The second point is in the defined PCI study, but also in target FFR, there was quite a lot of patients, 25 to 30%, that did not have an adequate physiological result, even though angiographically they were fine. Moreover, in the defined PCI cohort of patients, in 80% of those patients, there was a focal lesion. So basically, angiographically, things looked beautifully. Physiology showed something was not all right. And then imaging showed that there was a focal lesion which we missed on angiography that needs to be corrected. Knowing all this, I would opt for an imaging guidance when we only talk about the left main. So regarding the result in the left main, I would really prefer to see the imaging the beautifully as you did, and to be sure that the result is optimal based on imaging. I would use physiology on a second place regarding, as compared with imaging, regarding the results of the left main PCI. That's only my opinion. And only one comment about the ultimate trial, because I think it goes well with this. In the ultimate trial, which is an all-comer trial, so this is not left main PCI I was guided, it's actually the first randomized study in all-comer patients showing benefits of IVUS. What was interesting to me was that what was driving the events was not expansion or malapposition. It was basically the edges of the stents. It was the plaque burden, more than 50% at the stent edges. This is what was basically the predictor of events in the ultimate trial. I was in all comers. For left main, this is very much important. In this case, obviously you had stents where you landed, so it's maybe not as pertinent, but for the left main PCI, I think it's also important not only to check the expansion and apposition, which is what we look at when we do left main PCI, but following the results from the ultimate trial, it is also very much important to know where you land your stents, not only because of the edge dissections, but even more because of the plaque burden at the stent edges. So these are some comments. I think that imaging for left main PCI is something which I at least prefer and which I find very much important. But with physiology, you can be sure that there is not so much downstream disease with 0.94 IFR in this case.
Thank you. Andres.
Yeah, it's really, sorry, I don't know exactly what happened. Do you hear me?
Yeah, clearly.
Okay, then it's something happened. Actually, what I really want to say that Jan says very, very politically correct what I wanted to say. And, you know, we have experience around more than 4,000 PCIs for left main or even more. And but also we are really follow them, and we have participated in all studies and in registries, and as you know. And this is a bit, how to say, it is a bit strange, because in reality, what I really, how to say, I'm getting older, and I really try to do things very simple. It is, of course, I'm, you know, I'm foolish guy, I'm simple guy, and but on the other hand, I really want to finish this. If I can't finish, I really want to finish this in a nice way. And for this reason, I completely agree. And we did different kind. And you know, the first study with Nico Pils from first, I guess, this FFR, and then we switched to IFR, and then in FLAIR study we compare FFR and IFR, and now we have a new data, and that's no question. But I still believe, and this is what I completely agree with Jean that, and he says this very correctly, but I really don't believe FFR for left main. This is very, very difficult thing, because then you should count it everything other lesions, and this is again the question about is it the same left main and sleeve vessel disease and other things. And for this reason, I completely agree. And then you show beautiful case. And now we are in our center, we know to switch for with different strategy. And now we have 4-year follow-up where we compare, where we combine metal stent and scaffold, observable scaffold for this specific circ ostium. But in past, and maybe even in this particular case, my strategy would be to go for, first of all, not to use OCT but IOS, because then it's for me much easy to see. And actually, it's not for me, it is true. So we can much easy to see a real dimensions. Then what I would do, and how usually we do, then we really would treat this LAD proximal stent with cutting balloon followed by drug-eluting balloon, and also to check is it a real good expansion for this stent. And then it is very interesting point, what I guess, if I understood right, that what Jean mentioned, usually the plaque from LAD, and it is more than 90%, goes inside the left main. And then I would put a quite short but big diameter stent, which is for sure 4.0, and maybe then we can go for with non-compliant balloon to 4.5 or 5, and go for short this connection with I mean overlapping with this previous LAD stent. And then of course the question what to do with circ osteo. This is very difficult question. This is a difficult question at all. And in past, what we did, we practically tried avoid a second stent, because the problem is that if, you know, we are looking maybe for, if we're looking for 1 year or 2 years, it's one thing. If we're looking for longer period, the metal in ostium of circ is most dangerous point. This is about everything about shear stress, and that's why we actually to switch, and that's why our idea about the scaffold. But what we really seen in our follow-ups, that if you can leave circ with quite, optimal, even if it is not like totally 100% optimal result, usually the patients have not a compliance in future. And there is a couple things how to do that, for example, or with a high pressure non-compliant, and then you I guess Jean very well describe how to do that. You can go for, first of all, for pod, then you can go for the kissing balloon, or you can prepare left this circ with cutting balloon, or doesn't matter. And then again, and then to end it again with spot. But actually, it would be the strategy what I use. But what I really don't like, I really don't like to make this segment heavy. If you put more than one strut, you are making this segment heavy. You again going back, if you look on shear stress, is what we are having in Carina's. And practically, this is the biggest, where the low shear stress is the place which will be always a place of problem in future. For this reason, I would really to avoid the 2 stents in this one. But of course, it is again, it's not a panacea, because every case is a bit different. This is only my, like to say, as you know, maybe as I said, I maybe I can't to go so quick for this double crush and then super crush technologies, and actually I try to avoid them.
Thank you. We always try to avoid the stenting in left circumflex ostium.
No. This is not. We can't avoid always, but at least if we can, then it would be very good. Yeah.
Thank you.
That was a great discussion, and I'd like to thank Dr. Bubanishvili for showing the target FFR study, which of course was done in my own centre in Glasgow, but I can tell you there were no left mains in that study, and I suspect there were very few left mains in Define PCI, and I completely agree with what everybody's said, that you have to use intravascular imaging for left main PCI, whether you end up with one stent, two stents, or sometimes 3 or 4. That's a great sentence.
Indeed, we use the IFR in this particular case for assessing the results in in-stent restenosis, not for left main.
Sure. I totally understand. It was just a question about whether the IFR of 0.94 was good enough at the end. I think the imaging result was fantastic.
Yeah,
it was fantastic. Sure. Okay, so that's a great background now for the final talk that Andreas Arglis is going to give. I think he just told us that he's done over 4,000 left main PCIs. so we probably couldn't have anybody better to talk about this subject, but it is pretty controversial. And as you'll know, a lot of the controversy was triggered by David Taggart, a cardiac surgeon who actually trained with me in Glasgow many years ago, and then became the first ever professor of cardiovascular surgery in Oxford. And as you will know, ultimately withdrew his name from one of the Excel follow-up papers because he was unhappy about how the results were being presented. So hopefully by the end of this talk, Noble and Excel, why the controversy, will be a little bit clearer about whether or not there is a controversy or not. So thanks very much, Andreas. And if I could just ask you, would you mind giving this talk in English?
Yeah, I do. I do. It has been, this actually will be, it's because of the
of course, I appreciate you speak Russian.
Yeah, the expressions and definitions is for me more easy now. But and Keith, if you meet before me, David Taggart, please. Greetings to him, and at least with him here in Jurmala we spend a lot of times, and I invite you too. And we need them to do something good together. Yeah, but you said about this Tavis, that why. Yeah. So guys, thank you very much. It was really great session, and thanks to company, and thanks to chairman, and thanks to all panelists and speakers, because it was really interesting. And again, I'm going back because it's practically it is first, I guess, in 30 years when I spent 1 year in country, and in March it will be exactly 1 year. That's why it is so good to see you. But what Keith mentioned, this is very difficult topic, and actually when I thought that it will be quite easy, but it is not, and when I'm going even deeper in this, then I see that actually. But I will touch this, and then I will say this later on. First of all, I want to say that I really want to remind what happened in Excel, and what happened in Excel, and see there was a planned 2,900 patients, and then it was include only 1,900 patients, and as you remember, there was the primary endpoints a bit different from syntax. It's DSMI or stroke, and syntax score less than 32, and you see there's a science stent and CABG. And if you look on 5 years outcomes, then you see all-cause death, stroke, or MI at 5 years. There's no statistical difference. We can see that first 12 years was a bit better with PCI, and then there is cross the lines, but at the end of the day there is no difference. If you look on difference, this is always about analysis, how we actually analyzing this, and you see that the first year is much better for PCI. The year from first to second year, it is practically the same lines went. And if you look after actually, I'm sorry, and if you after 1 month, and if you look on after 1 year, then you see there is a divergence if you look on all-cause death, stroke, or MI for Excel. And then we of course we are going and look we look from why it's happened, and there, as you see, there's for many causes there's no statistical difference. And if you look here, actually also the stroke rate is no difference. We see that it is slightly favor to PCI if you look on stroke rate. no statistical difference. As I said before, the ischemia-driven revascularization was not defined as primary endpoint, but if you look on this as secondary endpoint, you see that of course in PCI group it was higher. If you look on myocardial infarctions, then again, of course, it is quite naturally that in first phase the CABG group has more MIs, but if you look on 5-year data, then again there's no statistical difference between groups. And of course, now we are becoming with most, I'd say, challenging part, because if we are looking on real trials, and this is, I guess, it is one of the always weakest point, but this is more about philosophy, I mean, how we can, in evidence-based era, to explain this. But if we look here, then we can look on this and to see, for example, about the death or all cause. Then we see that actually there is more for PCI group in comparison with CABG. If you look on cardiovascular, there is no huge difference. And then if you look, for example, non-cardiovascular, then undetermined cause of death, then you see that actually there is a higher in PCI group, and also when they analyze the more detailed, they see that it is because of cancer or other things. The same thing is if you look, for example, on cerebrovascular strokes, and you see there's a quite huge difference between stroke and also transient ischemic attacks. If we divide this in subgroups, but of course it is what we can't to use endpoints. So there is a analysis of 10 pre-specified subgroups. I guess it is very important because it gives us some insights and maybe some ideas how we can go in future. And for example, if you look here, then you see, if you look here about this all patients' age, and there is no huge difference, of course, if its age is bit more than 67. And I think it's quite interesting, and it is a very important signal if it's for more than 67 years old guys. And you should, for me, it is interesting because my son now he's a last year in residency in cardiac surgery, which is a bit strange. But on the other hand, it is quite interesting because we have so many discussions, and of course, when they are a bit, how to say, when surgeons are, when they need, we can help them. But actually, what I really want to say that I guess that this is a very important signal that after 65, 70 years, I guess it is, as you see, the CABG is doing even better like PCI. But there is one very, very important thing as well. There is no, as I said, huge difference in male and female. Females did better, and diabetes, it is practically the same. Chronic kidney disease, again, CABG did bit better, but look here of geographic location, and you see how important is where you are. If you look on geographic location, then you see that actually CABG doing much, much better in North America. And for example, in Europe, it's practically no difference. And in other part of the world, but there was a really small number. I'm not sure that it is very representable, but doesn't matter. You see the PCI did better. Now we are coming to Nobel study or Nordic Baltic British. Actually, the study we started, and I also was with the first day with this study, and we started like Nordic Baltic, and thanks to British colleagues and thanks Keith and other guys, actually we really finalized this study. As you see, there is completely different endpoints, and there was a death, non-procedural MI, repeated hospitalization, stroke at median 3 years with follow-up up to 5 years. And as you see here, of course, the numbers is less, but of course there is this repeated hospitalization. The one problem of Nobel study that we started in 2008 2008. And as you see here, we published this in 2020. So then you can imagine how long went the study, and this not always a really, I mean, best way how to do a studies. Nevertheless, I guess it is really important, but this is maybe also to can explain some controversies. And if you look here, then you see that that was a huge, huge discussion about that. And the keeper says, why you did the study like this one? And there is now it's a PCI is so doing so badly. And of course, again, there was a quite similar like in syntax study. You see, because of repeated causation, there was a huge divergence and statistical significant better for CABG in comparison with PCI. But look here. And if you look here, for me, it is quite difficult to explain this from one hand. On the other hand, it is quite, I guess there is some explanation. And I will touch this later on. If you look on syntax score more than 33, then you see there is there's no significant difference in PCI and CIBG group. It is completely different what we see in syntax study. If you look here in group, which is a syntax score was in middle, and from 23 to 34, and this was a 40% of population, of study population, also there was no difference. And now look back on this one. And if you read, it's completely different how it was in syntax study. And as you see here, if syntax score was less than 22, then you see that actually the CABG did much more better. And actually you see statistical significance is much higher in comparison than prior to CIBG, like with PCI. Of course, this is again rise the question: is this the same animal? Is the left main is the same like left main plus 1 or 2 vessel disease? No, and then there's all-cause mortality. There's no difference in 5 years, and the same. And then, of course, again, this rose many questions: how it could be that stroke rate actually in PCI group was higher than in CIBG group. It is only, in my mind and in my knowledge, it's only one study where we see something like this one. So there we are going to non-procedural myocardial infarctions and repeat hospitalization, but I'm not so sure that we should go so much in details. And here again, it is interesting question. That's what the previous speakers also mentioned. There you see we use Taxus stent, we use Cipher stent, we use biometric stent, and we use also Promo stent. Of course, and then we switched to biometric stent because the Taxus and Cipher was how to say it, the lead from stocks, and as you see here, actually, then this is this is the only with only one death. Of course it's tragedy, but it's only one death if we look on stent thrombosis. But others done very well. Of course, for me, it is bit strange that usually we have very rare cases of stent thrombosis for left main, because that's why we discussed before, we use imaging and we need to get a good minimal square area, and if MSA is more than 12, or of course then some Asian guy says that it is enough than 9, I'm not sure, 6 even, no, or 8, it's it's a different studies, but I'm not so sure. But I guess if it's more than 12, then it is very rare that we can find this. We can wait for these problems. Okay. Now we are, you see there's 2 articles. It's one of Excel study, the second is Noble study, and now we use, as you see, there is 2 controversies. In patients, what says Excel trial in patients with left main coronary artery disease of low intermediate anatomical complexity. Again, this is of course interesting. There was no significant difference between PCI and CABG with respect of the rate to the rate of the composite outcomes of death, so-called myocardial infarction at 5 years. And what is the interpretation of Noble in the causation of left main coronary artery disease? PCI was associated with inferior clinical outcomes at 5 years compared with CABG. Mortality was similar after the two procedures, but patients treated with PCI had higher rates of non-procedural myocardial infarction and repeat causation. Okay, about the repeat causation, it's more or less clear. About this non-procedural myocardial infarction and other things, it's of course we can discuss, but the studies show us what studies show us. No, we can also analyze the inclusion criteria, and we can analyze exclusion criteria. And as you see, the Excel initially planned, as I said, 26, and it was also powered for this, but the target decreased because of slow enrollment was not reached. And there was what Keith says, what was afterwards. Also recognize David Taggart, and as I said, he's a very nice guy, who says he's a rebel for this CABG, but actually this was a question about the MI definition. No, and of course you can go in details here. That's why especially to leave this, but I will not go in this one. But because I want to say, because lack of time, I want to say something what I really think about that. And you know what Greg says. Greg Stone says that Excel controversies. Is mortality greater after PCI compared with CABG in left main disease? And if so, doesn't this trump all? And second, why was the specific protocol definition of MI selected rather than the universal definition? Actually, not he says, but he answered those questions. And then was quite interesting, the answers, and actually I have not put this slide here, but one of the answers was that practically they also to recheck this with this universally definition, and actually about this specific definition they were agreed before. But here you see this there was the mortality was underpowered exploratory endpoints, and also the difference in mortality was modest, and other things. If you look on all studies, then you see that actually there is a no. If you look on long-term all-cause death, and even with Noble study, and also with long-term cardiac death, then you see that actually there is no difference. There is really no difference. And of course, again, this is about this. If you want to go and leave this, of course. So many people know that, but actually there was a why they use the one definition and the other one. But actually, I guess that this Excel definition, this procedure was not bad, because the point was, first of all, we know the CKMB elevation. It is one of the really important markers, and maybe it's most valuable. And actually, but as I said before, they also then to recheck with this universal definition of MI. And then one of the things that very usual after surgery, patients can't, because everything is painful for them, and know so many ECGs and others. And for this reason, this universal definition not always usable. But actually, it doesn't matter which definition you use. When they recheck with universal definition, they got the same result. And here again is a bit like this about, you see Excel as one of very important things was the interesting that if you have post-procedural MI, then of course the outcomes, and this is, I guess, it's very good sign. Doesn't matter in which branch, and specifically in the CABG branch, you see that that actually the result was much worse and in comparison with them where we had this MIs. So. And yeah, there is about some modalities, but again, there's it's a bit too long. And I will not go so much in this, but I really want to say the contrary of previous studies, the syntax score was not associated with this is not novel controversies with adverse outcomes after PCI compared to CABG. And this may indicate, but this not may indicate, we know for so many expert meetings that syntax score is usable for patients with triple vessel disease rather than isolated left main disease. And then remember this, what I showed you, this noble less than 22 syntax score. Post PCI IVUS looks like it's not enough only post PCI. We also need a pre PCI IVUS, and this is one of the answers. As you see, there was no statistical difference in MACE rate, but you see there is a real tendency better to post PCI for imaging, what would also Dr. Schwindley show, Professor us. But if you look on target failure revascularization, you see the statistical difference good to this one. About the Latvia, it's my bit personal experience, but this was published in somewhere in 2006 or something like that. But there we discussed also what is so important if we compare bimetal stent with, at that time, paclitaxel eluting stent, and actually the end of the day looks like that it's pre-treatment. And now I want to, again, you remember what I tried to explain about the States and Europe, and you remember that States did very well in CABG. Also, Europe did very well in PCI, in CABG, but Europe did even better in PCI. And then again, I remember this syntax bubble slide. And this is so important, actually. You see that sometimes in centers with great experience with CABG is not so good experience with PCI and vice versa. And I guess it is so important. And we, with this, becoming to one thing. We are becoming from evidence-based medicine to precision medicine. Also, environment really influenced on our result. I only to show you and this is not a good analysis, but there is we put in Noble study 70 patients in syntax 39, and then we bit to analyze. If you look in our data, and we have really good surgery, we can bit to say this is also very important that we exclude 12 because from those 12 was excluded because with no left main disease. But if you look overall, you see in 5 years, practically, of course, also it is not correct analysis because if you look here, there is a less CABG patients. Of course, every patient do give more percentage, but doesn't matter. If you look on this one, also with all these weak points, you see the PCI group doing very well. This is what we do, and we have, as I said, we have, it's more now than 4,000, but we really, this is what we could do. This is we really wants to show this Latvian IPSPI strategy. Does mean imaging, pre-treatment, doesn't matter which device you use, or the shock or rotoblade, or no, and then something stenting with appropriate size. This BVS I would not recommend, but we use BVS for if we do 2 stents, then we use for osteal circ, post dilatation for sure, or post treatment, and imaging. And one of the last slides, this is for sure. This is for sure. If you look back, and I remember this great debate, it was, yeah, I saw that it was yesterday, but it was some 10 years ago. This is a, and I even not to put this previous European guidelines where PCI was in red, actually, for left main. But if you see, this really depends on our learning curve. It really depends on our learning curve. It really depends on environment. This is one of these, examples. And of course, it really depends on who says about this philosophy and also skills and maybe infrastructure. That's why I guess those answers are not so easy. And I'm always very like this Leonardo da Vinci picture. As you see, there's a picture, there's the eye. Everyone knows eyes of Gioconda, but you see the every even detail, which is eye. Also, it's it's composite of details. But of course, we should not to lose this whole picture. That's all. Thank you very much, guys.
Okay, fantastic talk, Andreas, and I'm sure we can get Dave Target out to Latvia anytime, and you can do a debate.
Absolutely, David liked the beer. I don't know,
yeah,
but
no, he likes beer. He likes
beans. No, but he likes her. It's not only beer.
he's Scottish. He's Scottish.
Absolutely,
he likes beer. Yeah. But I just going to ask a couple of things. So first of all, I'm horrified to hear that you've allowed one of your sons to train as a cardiac surgeon. I have two sons who are doctors, but fortunately neither of them are cardiac surgeons.
If you can repeat this, I would record it. We always try to,
You realize he's going to be out of work soon. All he'll be able to do are type A dissections. Everything else will be done by transcatheter techniques.
Absolutely.
Okay. But anyway, seriously, the other important point, and this speaks back to the precision medicine discussion, you have to know the results in your own institution and with your own operators, as you say, and then critically, you have to present those results to the patient, and ultimately the patient, can choose. And of course, when you give patients a choice like that, very often they choose PCI. And I'd be interested to hear how it's done in Russia. Do the patients, if they're given a choice, do they prefer PCI?
The choosing process is the same, regardless of world region. In Russia, like as in Latvia and the UK, patient prefers always the less traumatic.
Yeah,
of course, this is so clear.
Yeah.
But this is interesting. You see, I guess that you touch a very important point. And for example, for us was after syntax study and after our results, it was quite difficult to even mentally sometimes to push patients to surgery in every case. Not in every case, but even, generally. But then, as I said, it is quite, but now, for example, because the patient, and we work very close, but now patients are a bit more to trust the center. And now, even I'd say it is more easy also to convince them to go to surgery, specifically because they trust also cardiologists. If they say that the surgery would be better. But if I understand right, what Keith says, that at least we need to explain and give those two chances to patient. And I guess it is only, and actually I learned from UK guys, from Australian guys in my student years, that always you should give this also the second opinion. And I guess it is only fair if we talk about, but yeah.
May I just make two comments regarding the data that you presented, which was, I think, wonderful for all of us. First is regarding mortality. I think there is a clear meta-analysis published in European Heart Journal just last year that demonstrated no difference, which you also showed in mortality. So I think that is an important message to be conveyed to both our peers and to the patients. So the finding of increased mortality, which was driven by non-cardiac vascular mortality in the Excel trial, importantly needs to be put into the context of other randomized trials, including, for example, the pre-combat trial, which had 10-year results, and which was conducted with the first generation DES. So conducting left main PCI with the first generation DES after 10 years did not yield any difference in mortality. And the second question is the question of myocardial infarction. And there, I think there are two parts. The first part is the periprocedural myocardial infarction, which should not be neglected, I think. And the definition chosen by the Excel is close to the SKY definition of procedural myocardial infarction. And just to put it in the perspective for our viewers, in the SKY definition, if there are no ECG changes, you would need a 70 times the upper reference limit for a periprocedural myocardial infarction following PCI. So 70 times.
With troponin.
Troponin, exactly. With troponin,
Yeah.
Exactly. So just to put it in perspective. So this is a significant myocardial injury. So I thought, at least in my opinion, that it was important for that definition to be chosen. And I think that it is important that if we speak about periprocedural myocardial infarction, to speak about those large myocardial injuries, which could be prognostically relevant, as you showed with a couple of my curves from the Excel trial. The second part is the non-periprocedural myocardial infarction. And I think that we need to admit that across the board in all of these trials, CABG was associated with the less non-periprocedural myocardial infarction, which I think are true findings. Now, what are the messages for our community based on this? I think they're twofold. The first is the principle. By principle, if you bypass a diffuse disease, then you would probably have a lesser chance of having some of those plaques creating a spontaneous myocardial infarction. But on the other side, I think that we could have a commitment to improve the technique and technology to reduce the risk of stent-related events and to use all of the contemporary therapies regarding LDL lowering, for example, to reduce the chance of non-stent-related events. So I think that this is how we could put it into perspective of our everyday practice.
I completely agree. You see, I'm not so, you know, it's a bit, it's so long. It's like Antonio says once, Colombo, that stop to talk about bifurcations and about me can also, you know, but it's this is of course a bit like it's very brutal, but and the same thing with bleeding risk and different kind of definitions. And I am agree with you. I'm completely agree. And what you says, you see, that's why I start to talk about precision medicine, because this is really depends, for example, if we really look, then you will see that it will really depends also on educational level of patients. And then again, we are going deeper because, for example, Latvia is a really small country and we practically can follow up each patient. That means that we know they are coming back to our GPs, they are coming back to center, and then we see, for example, usage of statins, AC inhibitors and other things. Even PCSK9 and inhibitors and so many things. And of course, it's again completely changing environment, as you says. And that's why I guess it is really depends, and sometimes it's very difficult. It's the same like with COVID now. It is very difficult now to, for example, to compare some, systems, and even sometimes for a smaller system, it's completely different how it's for bigger. We can't put a big system in the small. And that's why I think that, of course, you are right. No, I agree with you. But as I said, there is so many other variables. For example, I remember very well how we discussed with Patrick Sarai about in 2004 with syntax. For example, in Excel study was requested to use not statin, but even Sortis, or which is, you know, it is a bit strange, at least in our part of the world, because now we should prescribe generics and we should go for chemical these names, not for companies names, or this how to say this rosuvastatin. This how it's no doesn't matter, and this is, you know, there is so many details. That's why it is, of course, not so easy. But about this MI definitions, I agree. Only for me, the CKMB, it looks like more robust. I don't know. Maybe I'm wrong.
Sorry, guys. Please, because look at the time. It's so with the endless company, discussion. You know, let's continue this discussion. Andres, please, according to the agenda, wrap up by you.
Thank you. No, first of all, I want to thank very much to organizers and thank you for all panelists. And I guess it was fantastic lectures, fantastic, I mean, case reports, fantastic discussion. I guess Keith did tremendous job, and I'm really from heart say, because it's sometimes not so easy to guide this everything. But you see, as you've seen, if we don't like to interrupt this, that means that we have full hearts, and this is so nice. And I hope so that we will meet somewhere. And I also invite, or we can this group also. I can invite to Riga, because now we need to again to fill our hotels and and bars but maybe not in one month or 2 months, but hopefully in middle of in midsummer. And again, I guess thank you company for helping us about that. And I guess this is so important things, and bleeding risk and techniques and analysis of different kind of methods. And I am very happy about that. And thank you, Adil, to you because you host this and hopefully we will meet each other soon. And again,
thank you. Thank you. We will meet soon at the end of March.
Absolutely.
Okay. Thank you, guys. And on behalf of Russian Society, big thanks for all of you for this fascinating discussion, for participation, the very interesting presentations, and finally, be safe in this challenging time, first of all. And secondly, I do hope the borders will open soon and we will meet again in the near future in person. I do hope about this. Thank you very much.
Okay, thank you.
Thank you. Thank you.
Good night.
Bye. Thank you.
Bye. Thank you. Bye. Thank you, guys.